First, I want to thank the Ajanta Pharma for inviting me and sharing some scientific knowledge amongst my colleagues. It is a very interesting subject because a diabetic drug has become an important drug in the therapy of heart failure, and I will trace the history from the beginning onwards. Dapagliflozin is a SGLT2 inhibitor, and my previous speaker has highlighted that the location of these receptors and their effects on blood sugars, blood weight, and blood pressure. So what I'm going to talk now is impact of diabetes on cardiovascular disorders, and then how oral anti-diabetic drugs influence these disorders. Probably not many people are aware that diabetes increases the CV risk, mostly the vascular risk, by almost 2 times. And the impact is much more in a female as compared to a male. So reducing the CV risk in a diabetic patient is a major focus of diabetes management. Not many people realize that there is asymptomatic abnormalities of ventricular systolic and diastolic function is present in many of the patients with diabetes without manifesting overt heart failure. And heart failure is an extension of the same abnormality into a clinical manifestations. Remember that the heart failure that occurs in diabetes is not necessarily due to uncontrolled hypertension or as a consequence of an MI that occurs more often in diabetic patients. So there are some specific muscle disorders, what we call diabetic cardiomyopathy, as well as a cause for congestive heart failure in a diabetic patients. So the questions are, does lowering of the blood sugar reverse all these things? Any particular treatment is more specific for treatment of these patients? Or an interesting question has cropped up after the observation that the drugs given for diabetes, are they helpful to the diabetic patients in terms of preventing the cardiovascular disease, or can they cause more harm than the benefit to a given individual patient? This question of harm to the patient by way of increasing vascular events in diabetics has been raised after an observation by the drug called rosiglitazone. If you recall the history, FDA approved rosiglitazone in May 1999 for oral therapy of diabetes, because at that time there was another glitazone called troglitazone. We suddenly found out that they had a lot of hepatic toxicity, and that drug was withdrawn. This rosiglitazone at that point of time did not show any adverse effects upon the liver. So this was approved in a hurry, despite the concerns expressed at that point of time about adverse effects upon the lipids, in the sense that LDL-C got elevated. There was a lot of fluid retention in the body by way of edema. And there were, importantly, there was higher incidence of myocardial ischemia. So at the time of presentation to the FDA, these abnormalities have been observed, but it was still approved because it was a safer drug compared to troglitazone, which was withdrawn by the time. Now, this was approved in 1999. What happened between 1999 and 2007 was the drug was continued to be used for the treatment of diabetes mellitus, oral treatment. Very effective, and it did reach a very high, prescription in USA at least, until the paper by Dr. Stephen Nissen and his colleagues published an article in the New England Journal of Medicine in 2007 May. And it was a meta-analysis of the patients who were receiving rosiglitazone. And then they found that rosiglitazone was not at all cardiovascular friendly. And there was increased risk of MI as well as death from cardiovascular disease in people who were using rosiglitazone as compared to those who were using other anti-diabetic drugs. So how much was the impact? Impact was that those people who were taking rosiglitazone, the risk of MI was increased by 1.43 times. That is almost 50% increase in the risk of MI. And CV death, almost 60% increase in the deaths. Not to forget about precipitation of heart failure in a minority of patients in those who took rosiglitazone. Now, after this paper was published, FDA took notice of it, and then in December 2008, issued a guidelines regarding anti-diabetic drugs. And it said that from now on, all anti-diabetic drugs have to show that they are cardiovascular friendly and does not cause any aggravation of cardiovascular problems in diabetic patients. That's how the story started. And then, so the principle was, at least if you're not going to do anything good to the patient, don't do harm. So first do no harm was the principle on which FDA agreed on. And then it did put a safety warning on Avinda, that is the rosiglitazone, saying that it is potentially significant increase in the risk of heart attacks and heart-related deaths. So that safety warning was put there to alert the people that you are taking the drug, but then you can get into difficulties. That was the thing. Subsequently, FDA insisted that all anti-diabetic drugs, old and new, should prove that they are safe in patients having diabetes and vascular disease. So this is an analysis published in European Heart Journal. Remember, all the drugs are sulfonylureas or secretagogues, and this is in comparison with metformin, those without prior MI compared to those with prior MI. You will notice that except glyclazide, every other sulfonylurea was producing a worsening of the vascular events. This, not many people realized it when you compare it with metformin. So now the current thinking is, if you have to use a sulfonylurea in a patient with diabetes and vascular disease, glyclazide is the sulfonylurea of choice for the long-term treatment of diabetes mellitus in that patient. Subsequently, it applied to all other new drugs that came in, including DPP-4, SGLT2 inhibitors, and GLP-1 receptor agonists. You will see all these drugs were evaluated against MACE, that means major adverse cardiovascular events, which included vascular events and death. You see the CV death, myocardial infarction, stroke, and total mortality. And the last column is hospitalization for heart failure. Kindly note that saxagliptin in the SAVIOR-TIMI 53 trial showed that there was an increase in the hospitalization for heart failure in those people who took saxagliptin, either in isolation or in combination with other anti-diabetic drugs. That was the first hint that DPP-4, all DPP-4s are not equal, and some of them can do more harm than good. Then came the studies with empagliflozin, EMPA-REG outcome study. That was the first trial which showed dramatic change, both in terms of decrease in the vascular events and also marked decrease in mortality. And importantly, there was a marked decrease in hospitalization for heart failure. Now, this does not apply. The effect on heart failure was not applicable to GLP-1 receptor agonists like liraglutide and semaglutide. They did not have any effect upon the heart failure. So when we were using sulfonylureas and the first generation, second generation of oral anti-diabetic drugs, at that point of time, we were concerned only about hypoglycemia, lactic acidosis, and probable weight gain. But with the currently available anti-diabetic drugs, most of which are incretin-based era from 2010 onwards, now we are concerned about pancreatic safety, precipitation of heart failure, reduction of the myocardial infarctions, and reduction of the vascular diseases, and sometimes even precipitation of malignancy in thyroid. So the complication spectrum spread beyond hypoglycemia and lactic acidosis. So now there was, since the drugs were too many available for treatment of diabetes mellitus, there was a comparative study was done between the SGLT2 inhibitors compared with DPP4 inhibitors. Which one is better in a patient with diabetes and cardiovascular disorder? This is one of the study called CVD Real Nordic. This is a study, real world study. It's an observational study. So it is not a randomized trial. And there's a comparison between the SGLT2 inhibitor in those countries. Nordic means Norway, Sweden, and Denmark. These three countries, the SGLT2 inhibitor that was used, 90% of them was Dapagliflozin. And they did compare with other anti-diabetic drugs, most of which was DPP4 inhibitors in various ways. And what did it show? This observational study showed that Dapagliflozin decreased hospitalization for heart failure, in addition to decrease in the vascular events and also decrease the mortality. This was the first trial to show that. Now, this shows that major adverse cardiovascular events were decreased. The blue line is a DAPA and the red line is a DPP4 inhibitor. Here you can see that hospitalization for heart failure. Please note that these curves are diverging right from the beginning to the end. Say, by which I mean the benefit of decrease in hospitalization for heart failure started to be obvious within the first 2 to 3 months also. And then it went on becoming bigger and bigger effect as time passed by. Now, same thing about all-cause mortality. The mortality benefit was also seen within the first 6 months. And the longer you follow it up, the more it became obvious that dapagliflozin not only reduced the heart failure hospitalization, but also decreased the mortality. Now, there was some question whether it was only decreasing the heart failure or was it also decreasing any of the vascular events. This is a study done again from Boston. It's called a Declare TIMI 58, where they took patients with diabetes mellitus with CV events. One group was diabetes mellitus with established atherosclerotic vascular disease, either a peripheral vascular disease or a coronary artery disease or a cerebrovascular disease. And then the second group was diabetes mellitus with multiple risk factors, that is hypertension, dyslipidemia, and other things. And then they followed the patients for 4.2 years. The number of patients was quite large. It was 17,160 patients. The follow-up was for 4.2 years. And what did it show? There was a marked reduction in the hospitalization for heart failure. But then the impact on the major adverse vascular events was less obvious. But then if you break it down this group into subgroups, that patients who had an MI in the last 2 years had a better favorable effect upon the decrease in the vascular events as compared to those which it exceeded more than 2 years. So it was summarized at that point of time that administration of dapagliflozin soon after recovery from the MI has still got a benefit out of it, and it should be used strongly considered for secondary prevention of a coronary artery disease. Not to forget about prevention of heart failure hospitalization. So this is the same thing. Impact was more on heart failure hospitalization and less on the vascular events. There was a relative risk reduction of 27% in the overall population with dapagliflozin, less amount of hospitalization for heart failure by the dapagliflozin. So this is primary prevention of heart failure. That is, the first episode of heart failure was prevented, 36% reduction, and secondary prevention, that is preventing the recurrent hospitalization for heart failure, that was also decreased by 22%. So dapagliflozin made an impact, saying that this drug is one which is going to decrease the occurrence of heart failure in a cardiac patient with diabetes. So the next trial was a very interesting trial. So this trial, that is DAPA heart failure trial, took the notion that Is it applicable only for diabetic patients that this dapagliflozin decreases the heart failure hospitalization? Or is it also true that dapagliflozin, even in non-diabetics with heart failure, does it decrease heart failure hospitalization? It was a very big study, and there was almost about 5,000 patients, and the mean age of the patients was 66 years, with almost about a quarter of them were females, and the duration of the follow-up was 18.2 months. Remember, there were 60% were non-diabetic patients, only 40% were diabetics. One of the criteria for enrollment was the GFR, estimated GFR, should be more than 30 ml per minute per 1.73 meters square. And what they analyzed was total deaths, hospitalization for heart failure, and urgent visit to an emergency room because of worsening of the heart failure. So these three parameters were evaluated in this study, and it did show that compared to the placebo, that means no DAPA, there was a marked decrease in the need for hospitalization in those patients, even in non-diabetics with heart failure, there was a marked decrease. It is equally important to remember that it was independent of the age. That means it did have the benefit at every age, 40 years, 60 years, 70 years, and 80 years. And it is independent of the diuretic usage, which diuretic was used. And it also further decreased the hospitalization, even in patients who are already taking ARNI, that is sacubitril plus valsartan combination. And it also decreased the hospitalization even in patients who are on MRA, that is mineralocorticoid receptor antagonists. Were there any adverse events, specifically hypoglycemia? The answer is no. There was no incidence of hypoglycemia in these patients who were non-diabetics and who were taking dapagliflozin. And the adverse events were no worse than the placebo control. So again, these are all the same thing, but remember that this divergence of the curve starts within the first 2 months, indicating that it has to be a hemodynamic effect rather than any other molecular effects. So this, and the longer the follow-up, the wider the separation of these two curves, with dapagliflozin markedly reducing the need for hospitalization in heart failure patients. So what is exactly the mechanism of the CV benefit? Mechanisms can be broadly divided into hemodynamic benefits, where the preload is decreased because of diuresis. The afterload is decreased because of reduction in the systolic blood pressure and also in the diastolic blood pressure. There was also inhibition of sympathetic nervous system because although there was a fall in the blood pressure, there was no rise in the heart rate at all. And interestingly, there was no activation of renin-angiotensin system in patients who received the dapagliflozin, indicating that it was not decreasing the plasma volume, but it was decreasing mostly the interstitial fluid that is responsible for the benefit of reduction in the hospitalization for heart failure. There were other benefits also which may have contributed, like increasing the level of erythropoietin and inhibition of sodium hydrogen exchange at the myocardial level. So if the peripheral effects were so large, and then there was a decrease in the hospitalization for heart failure, one question was raised whether dapagliflozin had any favorable effect upon LV remodeling, by which I mean, was there any effect directly on the myocardium which caused a decrease or an improved function of the left ventricle or right ventricle? And this is a study called REFORM trial, wherein they studied LV remodeling in patients with diabetes mellitus and heart failure. It was a placebo-controlled study, and the method of evaluation, or the gold standard at that time, was using MRI for evaluating LV and diastolic volumes and LV and systolic volumes. And the dosage of dapagliflozin was 10 milligrams per day. And the follow-up was for 1 year, and the other arm had no dapagliflozin, placebo control. Interestingly, There was no change in the systolic function of the left ventricle, secondary to administration of dapagliflozin. But then there was an improvement in the diastolic function of the left ventricle, as evaluated by tissue Doppler imaging, wherein the E prime, which is a reflection of the rate of relaxation of the left ventricle, it was markedly improved. And further, there was a decrease in the LV mass. But mind you, there was no change in systolic function at all. There was no change in ejection fraction. Probably the follow-up was too short. It was only for 1 year. So where do we place the role of dapagliflozin in the heart failure? This is a consensus pathway for optimization of heart failure, published in the Journal of American College of Cardiology in February 2021, approximately about 3 months back. And then it shows first to give guideline dictated medical therapy for heart failure, which includes diuretics, ARNI, beta blockers, and MRA. Only then you should add an SGLT2 inhibitor in patients with reduced ejection fraction and heart failure. And the stages may be anywhere from class 1, class 2 to class 4 heart failure. Now, this is what we call, if you find a patient with heart failure and then they continue to be symptomatic in spite of all the guideline mandated medical therapy, then consider adding dapagliflozin, provided the kidney function is not very bad, as evaluated by eGFR or estimated GFR, more than 30 ml per minute per 1.73 meters square. And there is only one dose. There is no escalation of dose with dapagliflozin. You start with 10 mg and you end only with 10 mg. Are there any contraindications for usage of dapagliflozin in heart failure? The answer is no. It is not approved for type 1 diabetes because of increased risk of ketoacidosis. Unless you are hypersensitive to the dapagliflozin, that's the only contraindication. And as my previous speaker has said, probably you should not be using in people who are lactating. So because there is no data about the safety of the drug in that, and you should also not give it on dialysis patients because the effect is not yet studied. Should you observe any caution while you are giving the drug dapagliflozin for heart failure patients? The answer is yes. Remember, it can cause volume depletion. So you have to be careful and then adjust the diuretic dosage. There is a real risk of putting the patient into dehydrated state. So you please monitor the weight, monitor the blood pressure, both sitting and standing, so that there is no postural hypertension. If there's a postural hypertension, you need to think that you are over-diuresing it. Probably reduce the dosage of diuretic and maintain the dosage of dapagliflozin at 10 milligrams per day. Of course, as on today, there is a caution that you should not be prescribing it in pregnancy, and you should not be prescribing dapagliflozin if the eGFR is less than 30 ml per minute per 1.73 meters square. Are there any conditions wherein you may have to stop? You have to discontinue the drug dapagliflozin temporarily before any kind of surgery, or when the patient develops an acute kidney injury, or there is a clinical situation of fluid loss and reduced fluid intake orally, like incidental illnesses where gastroenteritis and other things wherein you may have to stop it. Or if the patient is suffering from urosepsis and pyelonephritis, it is desirable that you temporarily stop dapagliflozin. Same thing applies for recurrent mycotic genital infections, which is increased in patients receiving SGLT2 inhibitors. And of course, a very rare complication that is necrotizing fasciitis of the perineum, what we call Fournier's gangrene. So classically and conventionally, we have been telling you start dapagliflozin only after you complete the dosage of the other drugs you used for treatment of heart failure, that is diuretics, beta blockers, and ARNI, and MRS. But then recently there was an editorial published in one of the heart journals written by John McMurray and Dr. Weber, who said there is a need to rethink about the order or the sequence of administration of the drugs for heart failure, which is that the traditional one, that is the so-called green bar, what I have put it there. We have been using it for conventionally ACE or ARB after the diuretics, followed by beta blockers, followed by MRA, followed by RNA, and then only we were giving SGLT2 inhibitor. This is the classical teaching and this. But now, Dr. McMurray and Dr. Weber feels probably that is not the right way. There is a case now that you start off after diuretics, you start off with beta blockers. At the same time, add an SGLT2 inhibitor like Dapagliflozin. The understanding is any possible decompensation that can occur with the usage of beta blockers is compensated by diuretic effect of the SGLT2 inhibitors. So after 1 week after that, you add RNA and followed by mRNA. So this is the current or the proposed what we call rapid 3-step sequence